Okay, so let's transition a little bit now to melanoma. So as I mentioned, there's been an explosion of chemotherapy options. I want to go over some of these because they're so new that they haven't really honestly made textbooks, and I feel that our medical oncologists are using these, and we're consulted on patients, and we need to know about them so that we can make good surgical decisions. We'll talk about the role for surgical staging, and go over a little bit about estimating melanoma prognosis. So this is an overall schematic, and the purpose of this slide is not to memorize all these different acronyms and where they are and so on. But what I do want to draw your attention to is the yellow area here. And this is probably the most important part because we have drugs that target this pathway. So this is the BRAF pathway. I'll go into a little bit more detail about it, but basically there's a receptor, a tyrosine kinase receptor, and that activates different molecules. Then the central one that we'll talk most about is BRAF, and that triggers another molecule called MEK, and these have effects in the cell nucleus that control things like growth and survival and progression of melanoma. And again, so this is just the schematic of how this pathway is laid out. Let's next look a little bit at a walk down memory lane here in terms of the years at which different chemotherapy drugs were FDA approved. And so in 1976 or so, we had the approval of dacarbazine. Nobody's heard of this because nobody uses it anymore. It's that old. High dose interleukin-2 was debuted around 1998 or so. Has huge amounts of side effects, very difficult to administer. Again, we don't know about it because nobody uses it anymore. And then we fast forward to about 2011, where we have all these drugs within the last 4 or 5 years have been FDA approved. And it's just really an explosion. And what I want to go over is what these different drugs are, how they work, and what we need to know as surgeons to take care of patients who have received them. Okay, so let's talk a little bit more about that BRAF pathway that I talked to you about. So this is a serine threonine kinase. It functions by phosphorylating and activating mitogen activating protein kinase, and that has downstream transcription effects in terms of melanoma growth. The only patients who are eligible to have BRAF inhibitors are patients who have a mutation at codon 600. It's present in about 50% of patients with melanoma. So only about half patients of melanoma are actually eligible for this type of chemotherapy, and you have to do this genetic test on the tumor itself. This is not a germline mutation, this is a tumor mutation. You have to do this and prove that they have this mutation before they can get that drug. If you give it to somebody who has a wild type BRAF gene, it won't do any good. It's as good as placebo. And this is a highly conserved mutation because about 96% of the BRAF mutations are at this specific codon. There are other codons that are reported, but it's really amazing how that one codon is so vulnerable. BRAF mutations are not unique to melanoma. They're common in thyroid cancer, colorectal cancer, and they do confer a worse prognosis in those cancers as well. But we're going to focus on melanoma. The name of the BRAF inhibitor is called Vemurafenib. Again, this was the first new generation melanoma chemotherapy that was debuted in 2011. It's unique because it's one of the very few oral melanoma drugs. Most of the other ones are IV. It does have some toxicity. It's pretty unusual. You give it to melanoma patients, and about 30% of them will develop new squamous cell cancers because it has to do with one of the escape routes through that MEK molecule, which is downstream, that confers a susceptibility to developing new squamous cell skin cancer. So it's kind of weird. You're trying to treat one kind of skin cancer, you give chemotherapy, and it causes a different kind. Fortunately, as soon as you stop the drug, most of these will go away, and as surgeons, we don't have to rush into trying to resect these squamous cell cancers that arise in the setting of BRAF inhibition. This drug is really good because it has a high response rate, but unfortunately, resistance is very common and usually happens in short order within 8 to 12 months. One of the strategies to circumvent this quick relapse rate is by combining BRAF inhibition with that next molecule that I mentioned, MEK inhibition. And this dual inhibition has really cut down not only on the rate of squamous cell carcinoma, is way down, but it also prolongs the time to developing resistance. The next class of chemotherapy drugs are called checkpoint inhibitors, and these are immune modulators, and the two main components are CTLA-4 inhibitors and programmed death receptor blockade, and we'll go through each in a little bit more detail. So the CTLA-4 inhibitor drug is called Ipilimumab. It's the only drug in its class that's FDA approved right now. After Vemurafenib, within about a year or two, this was the next drug that was FDA approved. It's very powerful. Probably it had a higher response rate than a lot of other melanoma chemotherapy drugs for advanced disease, but it has some very significant side effects. So let's go over a little bit about its mechanism of action. So in order for the immune system to fight something, whether it's a parasite, cancer, a bacteria, it has to get stimulated. It has to recognize an antigen, and then it has to do something to counteract that antigen. So you have your APC, which is the antigen presenting cell, and this could be a dendritic cell, this can be a macrophage. There's a major histocompatibility complex that is displaying this foreign antigen. In this example, we'll say that this is a melanoma antigen. There's a T cell receptor, and the T cells are kind of the worker effector cells of the immune system. And there's a co-stimulatory event that has to take place between CD28 and B7. The B7 is on the antigen presenting cell, and the T cell has the CD28. Once that happens, once both of these two signals occur, then that T cell is activated and can differentiate, can directly cytotoxically kill its target, or can have other effects in the immune system which have the end result of killing the source of the antigen. So there are two possibilities here. So in a normal cell, what usually happens is there's this sort of built-in stopgap function, and this is really the function of CTLA-4. So this is a receptor that is expressed and says, hold on, this is not an autoimmune condition. Let's not beat up on ourselves. If you think about it, melanoma is really our own skin cells, and at some point we don't have an autoimmune response against our skin cells day in and day out. We only want an immune response against when it changes to cancer. But there are many shades of gray in between a normal skin cell and cancer. And how does the immune system know when to attack that abnormal melanocyte and call it melanoma? Part of that is through this use of the CTLA-4 receptor, that if it's activated, it tells the T cells, hold on, that skin cell is actually okay, let's lay off, let's not attack it. And so what we can do now with the CTLA-4 inhibitor is we can actually block that, and we can actually ramp up the immune system and say, look, I don't care if you're attacking skin a little bit, I want you to get rid of all the melanoma you can care to identify. And so the CTLA-4 blocker blocks that receptor there and says it's stimulated and now go attack it. And so as you would expect, the main side effects from these CTLA-4 inhibitors are autoimmune findings. One thing I should mention is that we talked about with the BRAF inhibitor that you have to have a mutant BRAF gene. There is no gene test, there is no lab test that you can use to predict who is going to respond to this chemotherapy or not. So if you look at this randomized control trial of patients with advanced melanoma, this GP100 is basically a historic kind of a control. There was a modest increase in overall survival when you compared Ipilimumab alone to GP100. This is a very expensive drug, and we're only able to achieve really a difference in about 4 months overall survival. This is the first generation drug. These small improvements in survival are not surprising with first generation drugs, and typically things get more cost effective with the second and third generation of these new mechanistic interventions. So these are the adverse side effects of Ipilimumab, and this is where as surgeons we need to be really in tune. So enterocolitis is probably the biggest one that we need to watch for. These are all autoimmune type things. Patients get vitiligo, they get hepatitis, uveitis of the eyes, they get bad dermatitis. Often grade 3, grade 4 toxicities land them in the hospital, and you will be consulted on them. So these patients present with colitis just like any other patient with a different kind of colitis. They have pain, they have diarrhea, nausea, vomiting, fever, and you take them to the endoscopy suite and you find patchy exudates along the mucosa, and just looking at it through the colonoscope, it's indistinguishable from other types of colitis. Now, what you do to treat the colitis is you give steroids. Unfortunately, prophylactic steroids doesn't prevent the colitis. And second-line therapy would be infliximab, and fortunately, in some series, only 2.6% of patients will present with perforation or need colectomy. So it's on the radar. Again, as surgeons, we need to know about this. So colitis sounds like a really bad thing, but there is sort of a silver lining. So overall, the response rate to CTLA-4 inhibition with Ipilimumab is about 14%, so it's not great. But the response rate of patients who develop enterocolitis while they're receiving Ipilimumab is 36%. So if you develop colitis, that somehow seems to boost your response rate. It tells us that your immune system is sufficiently ramped up, that you're killing melanoma, but you also have some of this collateral damage. But unfortunately, the onset of the colitis doesn't predict the onset of your tumor regression. So you can't use the onset of colitis as an endpoint for saying, okay, I can stop giving this drug now because now my melanoma has been treated. So we're going to shift gears a little bit now and talk about that second subclass of checkpoint inhibitors. This is the programmed death receptor mechanism. So programmed death receptors are something that are present on normal cells and are also expressed by some tumor cells. And basically, it's another one of these inhibitors. So if you have this tumor cell that's been already stimulated with our melanoma antigen here, and the T cell now is getting ready to get ramped up, if that tumor cell expresses this programmed death ligand and it's bound by the T cell, by its receptor, then that actually shuts off the T cell and it just puts it to sleep. And this tumor cell can continue to proliferate. And the mechanism of these of the PD-1 inhibitors, the programmed death inhibitors, is to block that so that the tumor cell can't put the T cell to sleep. The T cell, again, ramps up at your own endogenous immune system, and you can fight the tumor. The names of these are called Pembrolizumab is the first one that was approved. Nivolumab is another one. I don't think it's quite FDA approved, but it's close. These, again, are going to have some of the same side effects as Ipilimumab and the CTLA-4 inhibitors. You do not need any specific gene tests or lab values to predict who is going to be who's going to have a response to these checkpoint inhibitors. And if you compare Pembrolizumab, this PD-1 inhibitor, to the CTLA-4 inhibitor, you see that Pembrolizumab has a better overall survival than Ipilimumab and has far fewer adverse reactions. So the toxicity is dramatically more favorable for patients. You don't get nearly as sick with it. You're not admitted to the hospital as much. So I think quickly in the next couple of years, we're going to see Pembrolizumab really be superior and more highly utilized than Ipilimumab, which is good for us. Fewer patients that we have to help through with colitis. The last group of drugs that I want to talk about is the major representative is called, what used to be called T-VEC. The trade name is now called Imlygic. And this is an attenuated herpes virus, which has been genetically programmed to be able to infect all cells in the body, but it only replicates selectively in melanoma cells. And this takes advantage of one of the many mutations that melanoma develops in terms of transcription factors, and herpes virus cannot replicate in the normal cells, but it can replicate in melanoma cells because this virus has been genetically modified. It's also been genetically modified so that it produces GM-CSF, which is like Neulasta. So in other words, when a patient is when you have a patient who's neutropenic and you want to give them a medication to boost their counts, that's what you give them. You give them injected GM-CSF, but in this re-engineered virus, it contains the gene for GM-CSF. So it has two mechanisms of action. So the first is that this engineered herpes virus infects the cancer cells, and it causes replication, and it causes lysis. So it causes the melanoma cells to burst. And so that's the first mechanism of action. Now, after that melanoma cell has burst, now you have all this melanoma antigen floating around. You have GM-CSF that has primed your immune system to produce more antigen-presenting cells, more macrophages, and that combination of more antigen with more circulating immune cells gives you your second mechanism of action, which is your own body's innate immune system is able to now go out and better recognize melanoma and better kill off the melanoma. So this is really pretty revolutionary. There are very few other tissue types where this type of therapy has been successful, but it's really exciting, and this is something that we're actively using here at UAB. And if you're with me in the operating room next week, we'll be operating on somebody who's had this. There are some complete responses to this that have been recorded, and it's pretty exciting. Now, with all checkpoint inhibitors, whether it be PD-1 inhibitors, CTLA-4 inhibitors, and even the viral vector that I just mentioned, they have this peculiar tumor-killing kinetic, where it's not direct cytotoxic therapy. It's really two steps. First, you prime your immune system, and then the immune system kills the tumor. And so the weird kinetics is that if you have this baseline scan, you see all this metastatic disease here, that's bad. 3 weeks later, after giving one of the checkpoint inhibitors, things actually get worse. That's called tumor pseudoprogression. And so again, as surgeons, we need to be aware of this, and when we're evaluating a patient, and understand where they're at in their therapy, so that we can better make surgical recommendations. Because if you're patient and you wait, that same patient will have near resolution of their disease several months later. So this is very peculiar to how some of the checkpoint inhibitors work and how these viral vectors work. It's called tumor pseudoprogression. Things get worse before they get better. I'm going to shift gears a little bit and talk about the rationale for melanoma lymph node staging. So again, just like for pancreatic cancer, there's a prognostic element, there's a regional control element, and again, stage migration. This is especially true for melanoma, where we have all these new clinical trials, but they're predicated on knowing what stage they're in, because if we see that a drug is performing quote-unquote poorly, maybe it's not just because that drug doesn't work, maybe it's because we have a heterogeneous patient population and we're not actually testing what we're trying to set out to do in our hypothesis. So good lymph node staging helps accurately stage a patient and fit them into appropriate clinical trials. So the indications for sentinel lymph node biopsy, as you'll see, just to kind of review for the medical students and so on, is if you have a melanoma which is at least 1 millimeter in depth. All melanoma patients with at least 1 millimeter depth need a sentinel lymph node biopsy because their risk for having a positive sentinel lymph node is at least 5%. If you have a melanoma that is thinner than 1 millimeter in depth, then you need to look at other high-risk pathologic features like the presence of ulceration or the presence of increased mitoses in the primary melanoma site. And even in patients with thin melanomas less than 1 millimeter, the presence of ulceration or increased mitoses are also indications for a sentinel lymph node biopsy. If you have a positive sentinel lymph node biopsy, then the textbook answer in 2016 is still to do a completion lymph node dissection. That's probably going to change in the next 5 to 10 years as we get new randomized data that's still maturing right now. But for now, that's still your board answer, and that's still your day-to-day answer with a few caveats. In the situation of a positive lymph node in the groin, this is a more difficult situation because the outcomes from inguinal and pelvic lymph node dissection are much worse than for an axillary or a neck dissection. It's just a much harder operation because of the anatomic site. Take this patient with a BMI of 48, for example. Their head would be here, their feet would be down here. I've marked out their pubic tubercle and their anterior iliac spine here. And usually I integrate this into one incision that spans the inguinal crease, but because they're obese and this area right by the inguinal crease tends to be the hardest point to heal. I tried separating them. I tried to do everything to improve their wound healing because in this patient population, this is just such a difficult incision to heal. There's a high rate of wound complications. The incisions are painful. They get swelling and so on. What if there were a better way? So recently, what's been promoted is an endoscopic inguinal lymph node dissection. And instead of using that big open incision, I use 3 laparoscopic ports here for the inguinal component, and I'm still getting out all the inguinal contents, and this, the landmarks for this would still be the pubic tubercle, the anterior iliac spine, and where the adductor longus and the sartorius muscle intersect. And so you're still clearing out the same anatomic space that you would with the open operation. This has been reported in isolation for the inguinal lymph node component. You can find groups doing this. You can find gynecologic oncologists who are doing the iliac and obturator lymph node dissection. But this is something unique here at UAB that we're doing by actually combining them in appropriate patients. Really, nobody else has described this in the literature so far, and it's exciting to be able to put together the first cohort of this. So let's see what that looks like in video here. So this is a short video from one of my patients. So here we have the obturator nerve and obturator artery. Even when you're doing an open operation, for those of you who have done this with me, you never get that great visualization. This up here we'll start to see the, here's Cooper's ligament, which would be more over there, the external iliac vein, the internal iliac, the external iliac artery here, and now this is the superficial canal, where you have the femoral canal, the sartorius that I showed you, femoral nerve right there, and now here is the saphenofemoral junction and the femoral artery right next to it, and here's coming from the superficial inguinal compartment and going up into that deep pelvic iliac obturator space that I've already dissected. This is really quite novel and it dramatically improves patients' recovery from the operation. It's nice to be able to offer it to our patients here at UAB. So are we still doing the same operation and in terms of lymph node retrieval? And the answer is yes. These are not trivial specimens that I'm pulling out. This is a 15 centimeter ruler, and so this is the same dimensions of lymph nodes that you can pull out through these small incisions. This patient had very friable tumor. The yield, the number of lymph nodes that you get out from the iliac space is always smaller, so it's not surprising that that specimen just physically looks smaller, but that's still pretty equivalent to what you would pull out through an open operation. Last topic I want to quickly go through is a new way to prognosticate melanoma outcome. And this has really started from the fact of kind of a reflection on the inadequacies of our AJCC staging, where you have stage 3 patients are node positive patients, stage 2 patients and stage 1 patients are node negative. But we have this unusual phenomenon where if you look at stage 2C patients and you compare them to 3A and 3B, stage 2C has a lower survival than patients with a higher number stage. And so there's, that just doesn't quite make sense. And one company has sought a way to look at things in a different way to make this a little bit more clear. And so this is a proprietary gene assay that is used by taking paraffin blocks of the primary melanoma, and they look at 31 genes, 28 melanoma specific genes and 3 controls. It's called DecisionDx. And there's proprietary weighting of each of these 21 genes. And so your result is you have a patient who has a class 1 test or a class 2 test. The class 1 is a favorable prognosis, and the class 2 is a worse prognosis. Their endpoints that they've done in their studies are mostly retrospective. They've looked at distant metastasis-free survival, recurrence-free survival, overall survival, and time to recurrence. And their genes cover a number of different types of function of melanoma, some of those things that were outlined on that very first BRAF mechanism. And the purpose of this is not to memorize all the genes and so on, but just to show you that they're targeting different functions of the melanoma. So it's not just a one-sided kind of a test. And when you look at some of their validation data, you can see that patients with a class 2, in other words, the worst outcome, have thicker melanomas. They are higher stage, and they have a higher rate of ulceration, so it makes sense. Worse outcome with worse pathologic features. this was also shown to be true in a multivariable analysis where it has a very favorable hazard ratio when you compare it to other things like AJCC stage and ulceration. Again, so this is multivariable data. I should say that these are very small studies though, about 200 patients and so on, usually of just a few institutions. It's not prospective, and I would say this is not standard of care yet, but I'm just sharing it with you because things like this, if this ends up not being the one, things like this are going to be more and more common in the coming years in your practice. This is that time to recurrence. So a class 1 patient will have a time to metastasis of about 4 years compared to a class 2 patient. So you might be able to use it to predict or say how long you need to follow a patient or survey them after the diagnosis of melanoma. So they've also applied this test to stage 3 patients, in other words, node positive patients. The major limitations with this paper were they didn't really tell you how many patients got a PET scan and an MRI, and again, you have these stage migration issues. You're telling me that that this product is good for telling me the outcome, but you haven't really told me how you're assessing that outcome explicitly, and you don't tell me how many patients underwent completion lymphadenectomy. So if I'm trying to say that I can predict who's going to have a metastasis, but I don't know who actually had a good lymphadenectomy, then that's an obvious limitation of the paper. But what they do show is that they show that if they use sentinel lymph node biopsy to predict outcome, it's actually superior if they use the class 1 versus class 2. You can see 71% versus 89% and 62 versus 55 here. So they get better curve separation. And remember, with our little thought experiment, that's what we were trying to maximize, better curve separation. And if you combine the sentinel lymph node status with this gene test, they get even better curve separation, which is illustrated in this point. So how do you apply this data? There's really no prospective data available. This is not an appropriate substitute for a sentinel lymph node biopsy. Maybe it might help you decide how long to follow an early stage melanoma patient in terms of regular skin exams. And it might help you decide which patient with very small lymph node metastasis might or might not need a completion lymph node dissection if they have a lot of comorbidities like on Coumadin, 90 years old, just had a heart attack 6 weeks ago. But this is not standard of care right now. I'm presenting it to you because it's new and exciting and something that you might see in the future. And so I'll just close by going over a case summary. This is a woman that really was treated in a way that you would have never dreamt of for melanoma before. She had a relatively thin melanoma. She had a wide local excision back in 2007, but declined a sentinel lymph node biopsy. Then 7 years later, she presents with a palpable groin mass that was biopsy-proven melanoma. It was BRAF mutant. And on the PET scan, she has lung disease, she has peritoneal carcinomatosis, and of course she has this palpable inguinal lymph node. She gets Ipilimumab. She has some toxicity. She has a 30% total body surface dermatitis. She gets some more Ipilimumab. The restaging scans show that she has the lung and peritoneal metastasis are completely gone, and the only disease that persists is that palpable groin lymph node. I take her to the operating room. She gets a minimally invasive lymph node dissection, and now she's NED. I mean, 5 years ago, you would have never dreamt that a patient with lung metastasis, carcinomatosis, and a palpable groin node would be NED, but it's something that is here today, and we have the privilege of helping patients through. So with that, I'll just finish up and take any questions.